Okay, thank you, Anthony. I think Anthony gave us a good background. So I'm going to focus more on the patient pathway and the curriculum and the extended training platform where the teaching and where the cognitive function must reach the fingertips. So I was thinking of just explaining the patient pathway, because as Anthony sits in Cape Town and I sit in Pretoria, the public sector and the private sector differs. So the private sector is a pretty linear pathway. If a patient has a problem, they can present either at a psychologist or wherever they want to, or a general practitioner, and they get referred to the specialist. These specialists may be sexologists or not. When you look at the public sector, however, the patient has to present at the primary care level, and I'll show you the pyramid of the healthcare system. And there it's nurse-driven. So the nurse will then make the call where this patient will go. And she can either refer this patient back to the social worker or the psychologist or whoever she thinks is appropriate, or to the general practitioner. The general practitioner in his mind will then make the call, either a psychologist, social worker, or for that matter, a specialist, which can be a urologist or a gynecologist, or wherever they feel they want to refer the patients to. Now, the training also happens in this public sector. So in the undergrad training, basically the training happens in the primary care level. So as you can see, the public sector is driven by nurses, and then the traditional practices like the traditional healers, sangomas and yangas, etc., is still a line that runs through the healthcare system. Media is very strong, and these some of these NGOs that Anthony referred to, like the Men's Clinic, is widely publicized, but not all the patients will have the money to go there. So if we look at the public healthcare system, it's an inverted pyramid. So at the bottom is the primary care level. And then there's community healthcare centers, which is a 24/7 center, but it's also primary care doctors and nurses. And the mainly nurse-driven. So if the nurse makes the call, the patient can continue in terms of the healthcare process. Otherwise, it stops there and the nurse treats whatever she thinks is necessary. The district hospital can only be accessed by other professionals, like your paramedics, psychologists, social workers, who then refer the patient there. So it's not a linear process or as accessible as the private sector. It's still that linear process from the basic referral point of primary care. And then the sexologist that we know of in this country sits at the tertiary level most of the time. So a few of them are in family medicine, but mostly private family medicine. The ones in the public sector, not so often. So the training, as I said, in the primary care level. So if we look at the medical training in terms of the curriculum, we talk about the declared curriculum, which is that primary roadmap to learning. So the declared curriculum will cover the topics of sexual medicine that we are talking about. Then there's the taught curriculum. And this is what Anthony also alluded to, that there's this disjointedness. They don't talk to each other. And I will show you what happens at Wits University. We have topics, but if you ask what's the scope of these topics being taught, nobody can answer you. Then there's the learned curriculum, and that's the part to be assessed. So if you look at assessment drives learning, and you ask how is sexual medicine assessed, and I'll talk a little bit more about that later, then you realize that we don't assess what we teach. The biggest part of learning happens in the hidden curriculum, that unexplained, unofficial, unwritten curriculum. The baseline, where the undergraduate medical officer or medical student is actually seeing the patient. So I want to use Bloom's taxonomy to explain to you why this learning doesn't really flow through to become practice. At the bottom is remembering and understanding. So that's the baseline, recall. You learn, this is the anatomy, this is what it is. If you look at the undergrad program at Wits University, which is not different from other universities, remember we are all registered by a health professionals council. So the minimum standard for that degree is spelled out and accredited, and that's what's happened. So you can have small deviances in topics or domains, but technically sexual medicine will have X amount of notional hours within a program. And in most of the universities, it falls within the scope of family medicine, mostly in terms of the patient contact, the basic skills, and then thereafter in the specialities like gynecology and urology. Now, if you look at this baseline, you will see that the students up to the year that they have to exit the undergrad program are basically only at the understanding level, a little bit of applying, which happen in the academic health complexes, and I'll tell you a little bit more about that. But if you look at the time that they spend there, nothing really turns into practice. So let's look at the graduate entry medical program. So students enter us with a basic three years degree, any basic science degree or social science degree. They have certain criteria that they have to meet, and then they can enter the medical program, like a pre-med. So in the first year, and these are own didactic lectures, they will deal with gender-based, sex, gender, and gender-based violence. So that is what the focus is. And as you can see, no communication, how to engage into sensitive matters, no practice lectures, only didactic. Second year, they do a reproductive block, where again the focus is on reproduction, missing communication. In the third year, these students have lectures over 2 days. Now, you will know that if you're good, you can have about 6 lectures in a full day. And that's mainly primary healthcare topics. Sometimes, if there's time, they will do the sexual response, but most of the time it's omitted because of other more urgent things that they have to deal with. Then they work 10 days with preceptors, and that can either be public or private. In the integrated primary care, which is the final year of the medical students, they have 1 day orientation, which includes then a few tutorials. They have once a week a tutorial of 90 minutes, and they have 1 telephone conference in that block of 5 weeks. And in those 5 weeks, there are 24 consecutive days in primary care clinics on the extended training platform. Now, what is before I go to the extended training platform, I just want to say to you, if you now look at the taught curriculum, where we don't have any evidence of the scope of the content, we look at the learned curriculum where it's not assessed or not properly assessed. It's most of the time 1 or 2 multiple choice questions, or then, for instance, an OSCE on reproductive health or a STI or family planning for that matter. Then you will see that there's a disjointness, and communication on these topics are often taught in the hidden curriculum, and that research also indicated. So if you look at the hidden curriculum, it's the extended training platform. Now, I've given you WITS as an example, but WITS is, all the universities have the same model of training. So WITS is in the center, and then when the students go out for their practicals, for their clinical experience, they go to academic health complexes. And you will see WITS have 6, as close as 4 kilometers, and as far as 442 kilometers from WITS. In these training platforms, the doctors or the supervisors or preceptors of these students are usually clinicians that's working in the healthcare system, and then they have a responsibility to also train. So not all of them train, but some of them do. So if you look at the academic health complex, and now keep in the back of your mind that I've actually explained the pathway of the students, of the doctors, of the patients, sorry. You will see that there's vast socio-demographic differences. We have, for instance, rural areas versus highly cosmopolitan areas. So, for instance, Northwest Freiburg, which is rural farming, versus Johannesburg. We have 12 official languages in South Africa and 35 spoken languages, which makes communication more than just a challenge. Poverty, and then as Anthony said, the unemployment rate, but in these areas, specifically in WITS, unemployment can be as low as 23% and sometimes up as high as 42%. A doctor sees between 25 and 40 patients per day. So there's long waiting times for patients, there's a lack of resources, there's often poor work ethics, but some of these doctors who's working in the public sector also have private practices. So at 12 o'clock, he runs away to his private practice because that's where he makes the money. There's also poor administrative support, and then the quadruple burden of disease. So if you look at the disease profile, you will see that the focus of the curriculum is often focused to the burden of disease, and sexual health and pleasure, sexual dysfunction is not a priority. So there's also a problem in terms of the preceptor or supervisor student ratio. It's sometimes as low as 1 to 6, sometimes as high as 1 to 8. So in one of the academic health complexes, and I took Dr. KK as a combination of city and semi-rural, 6 family medicine registrars, 8 final year medical students, clinical associates, and then the Nelson Mandela Fidel Castro collaboration students. So those are the South African students who trained in Cuba and who's returning to South Africa, and then 20 interns. So it's quite a burden of training in that academic health complex. So the training also does not exclude this preceptor from service delivery, and the teaching is usually about 30% and service delivery 70%. No role modeling. And sexual medicine is not a priority. If you look at the logbooks that the students may bring back to the university, things like sexual history taking, sexual dysfunction, even gender-based problems are not in the logbooks. And then the communication that must happen in this hidden curriculum, where the students get their training, does not happen. So that communication bridge between the learned curriculum and the clinical practice is non-existent. So in conclusion, if we look at the broader medical sexual medicine curriculum, you will notice that the training is often disjointed. And there's no alignment, not between the cleared curriculum or the learned or even the hidden curriculum. And the skills transfer is just not happening. There's no spiral of learning. And sexual medicine does not have a dedicated place in the curriculum. So teaching is fragmented. So what's the opportunities? Well, perhaps because I'm a social worker, I have this bias to say that it's time that the scope of that sexology training is adjusted to the scope of practice of various professionals to allow more of us to have that entry point to either do appropriate referrals or to do what's within our scope of practice to help patients. And that will actually also help the affordability issue. We can promote sexual medicine and family medicine, and I think we are doing that. Anthony also spoke about the diploma that's coming up, that's under the auspices of family medicine. And then it's important that sexual medicine must be an autonomous discipline with a dedicated space in curriculums. So if it's not an independent discipline, it will never gain its place in logbooks, and the training platform will keep on ignoring it. Stellenbosch University is actually now sort of running or ahead of the rest of the universities. They got money to have a specific department to develop a pleasure sexology curriculum. And they are looking at the spiral of learning from the first year up to exit point, where they will actually teach sexual medicine as well as the communication, where they're going to use these communication dyads to practice, to get the cognitive part of sexual medicine into those sensitive issues that patients in South Africa do not want to face, or professionals do not want to face. So that's for us. We are all watching them and hoping we can learn from them. And then it's also important to create awareness of sexual medicine on the clinical training platform. Now, Sasha, with Anthony's help, is doing a lot of work in terms of CPD training. But because the clinical training platform already have an abundance of CPD, continuous professional education points, they don't always see it necessary to go and pay extra money or belong to a different organization to get more points. And then the ideal would be that more universities can benefit from financial support to actually establish independent units. So I think that's my talk for the day. Thank you very much.